Hi, my name is Sarah Lyman, and welcome to my poster presentation. Before I begin, I would like to say thank you to my site mentor, Jennifer Foreman, my advisor, Dr. Amy Dara, and my committee members, Dr. Monica Robinson and Dr. Erica Kemp, for assisting me throughout my capstone project and doctoral experience. First, I completed a systematic review, and my research question asked, in hospitalized adults with delirium, how do non-pharmacological interventions affect duration and incidence of delirium? I determined whether studies met the inclusion criteria, extracted study information into an evidence table, assessed study quality and bias, and graded the overall strength of evidence. As a result of the systematic review, I found that evidence supports physical and occupational therapy, or PT and OT, as an effective non-pharmacological intervention for reducing the incidence and duration of delirium in hospitalized adult patients. Under literature review findings guiding clinical reasoning, you can see the PRISMA diagram, which includes the process of selection of studies. Next, on the poster, I have described my doctoral experience at a suburban hospital in Ohio in the acute care setting. I primarily focused on patient care, including evaluating and treating patients, making discharge recommendations, communicating with other disciplines on patient progress, and educating patients and families on various handouts and adaptive equipment. In addition, I had the opportunity to shadow three different disciplines, including the psych physician's assistant, the pain management physician's assistant, and the speech language pathologist. I also created several on-site projects, including educational handouts on delirium and various exercises, as well as a handout on PT and OT treatment ideas for COVID-19 patients, as research is currently limited on the topic. In addition, I created a fine motor kit along with an instructional handout for the OT staff to use. Lastly, on the poster, a primary focus of my doctoral experience included a case study. I implemented the protocol as defined by the literature. The patient A tested positive for delirium during her hospital stay. A received 25 to 40 minutes of PT and OT daily for the duration of her stay. As you can see in the table timeline of care, during days 1 through 3, A was positive for delirium and unable to receive PT and OT due to being unable to follow simple commands. During day 4, A fluctuated between positive and negative for delirium and showed an improvement in PT 6-click score. The 6 clicks is a functional measure assessment used in the acute hospital setting. On day 5, A tested negative for delirium and showed an improvement in OT and PT 6-click scores. In conclusion, while A was receiving PT and OT, her duration and incidence of delirium decreased. PT and OT is indicated as an effective and feasible intervention for the management of delirium. Healthcare professionals, patients, and patients' families need to be further educated on this intervention. If you have specific questions about my poster, you can email me at lyman.60@buckeyemail.osu.edu. In the meantime, here are three questions I anticipate you may have for me. First question, what causes delirium? Causes include, but are not limited to, advanced age, sleep deprivation, physical restraints, UTI, bladder catheter use, immobility, diminished activities of daily living, alcohol abuse, severe illness, and hearing and visual impairment. Second question, what did you learn from the other disciplines you shadowed? From the psych physician's assistant, I learned about the criteria for diagnosing delirium according to the confusion assessment method. From the pain management physician's assistant, I learned that pain is psychosocial. For example, two individuals could go through the same trauma, and one individual's tolerance of pain may be perceived completely different than the other individual's tolerance of pain. Pain tolerance is impacted by attitudes, beliefs, and childhood events. From the speech language pathologist, I observed a modified barium swallow and learned about discharge recommendations for diets. Third question, what types of adaptive equipment did you educate patients on? I primarily educated patients, especially patients post-op hip and knee replacements, on lower body adaptive equipment, including long-handled sponge, long-handled shoehorn, sock aid, reacher, and dressing stick. I also educated them on an elevated toilet seat, shower chair, and grab bars. Thank you for listening to my poster presentation. Thank you again to my site mentor, advisor, and committee members for their time and assistance.